going to continue our lecture on respiration with what makes you breathe. Anybody have an idea? What makes you breathe?
Brainstem.
Your brainstem. What happens in the brainstem that makes you breathe?
The brainstem is a sensor for carbon dioxide in the blood.
Your brainstem has a sensor for carbon dioxide in the cerebrospinal fluid.
Okay, yeah, there you go.
That's what you were trying to say.
That's what I meant.
Yeah. Okay, so your brainstem senses the pH balance of your CSF fluid. CSF is cerebrospinal fluid. Okay? So your brainstem senses the pH balance or the pH levels of your cerebrospinal fluid. And the presence of carbon dioxide causes your cerebrospinal fluid to be acidic. And these changes are so minute that you don't even notice them. Okay? These changes happen without you even being aware of it. There's a name for this. This is how, when you're born, this is how you breathe. This is what causes you to breathe. And the name of this particular respiratory drive is called the carboxyl drive. Okay? The carboxyl drive recognizes, your brainstem recognizes the fact that there is too much carbon dioxide there and it forces you to breathe. What does breathing do? How does breathing help this situation?
Brings in more oxygen.
Brings in more oxygen. What else does it do?
Gets rid of carbon dioxide.
It gets rid of carbon dioxide, thereby adjusting the pH level of your cerebrospinal fluid. Okay? Most people breathe through the carboxyl drive. That's the natural way to breathe. It's a healthy way to breathe. It's the way that most people have learned to breathe. And that's just how it works. However, if a person's cerebrospinal fluid is consistently slightly acidic, you can burn out your carboxyl drive. When you burn out your carboxyl drive, you still want to be able to breathe, right? So your body shifts to a different type of respiratory drive. Do you know what the other type of respiratory drive is?
Hypoxic.
Hypoxic. And what does hypoxic mean? Let's talk about medical terminology here. What is hypoxic?
Low something. Because hypo means...
Hypo means low.
Low oxygen?
Yeah, this is a condition of low oxygen. Okay? All right? So, instead of sensing that there's too much carbon dioxide, your body senses that there's not enough oxygen. Sounds like the same thing, doesn't it? Doesn't it?
Kind of.
Kinda. But it's not. Instead of sensing the pH in your cerebrospinal fluid, it starts to realize that you don't have enough oxygen. Okay? So, instead of breathing because your pH is too high, you breathe because your oxygen is too low. Now, breathing because your oxygen is too low, it takes time for your body to adapt to using a hypoxic drive. This isn't something that, you could get smacked upside the head and all of a sudden you would have a hypoxic drive. It doesn't work that way. Okay? You have to have worn out your carboxyl drive in order for your hypoxic drive to work. This causes a problem for us as EMTs. Why?
First, what would cause it to wear out, the carboxyl drive?
Continued high levels of CO2 in the cerebrospinal fluid. So the pH is...
So like, you know, carbon dioxide poisoning?
No, because it takes longer than that.
Okay.
Okay?
Someone,
But, pardon?
could that happen with like someone with asthma or?
Somebody who has COPD. Okay, someone who has COPD can't exhale as much as they need to be able to exhale, so they can't ever blow off all their carbon dioxide, right? So over time, there are physical changes that happen with COPD, but there are also biological changes or chemical changes that happen with COPD. And in many cases, our patients with COPD will have a hypoxic drive.
I would guess the problem for EMTs is if you put oxygen on them, you could mess them up, right?
Right. Why are you going to mess them up?
Because you're constantly giving them oxygen, so they basically stop breathing.
Why?
Because they're
in the hypoxic drive.
they're reversed than normal people.
They're reversed. So they're breathing because they have low oxygen levels. And if you provide them with oxygen, they no longer have low oxygen levels.
Yeah.
So their respiratory drive is gone.
You basically suffocate them with
You
oxygen.
basically suffocate them with oxygen.
Is there a way that you can tell what when they?
Ask them if they have COPD. Maybe?
You can ask them if they have COPD. The presence of COPD does not necessarily mean that they have a hypoxic drive, though. And if you have a patient who you feel like needs oxygen, you don't withhold it. If you apply oxygen and they get worse, you can always take it back off. Okay?
Would you have them start breathing into a bag or anything at that point?
The science behind using a brown paper bag in order to help a person get their acid-base balances back has kind of gone out the window. So if you were at a point where it was either we need to get their carbon dioxide levels up really fast, or they're going to pass out and they're not going to breathe on their own, then I suppose you could try it. But as soon as you stop providing them oxygen, this drive is going to kick back in again. Because this drive is not based on the presence of carbon dioxide. It's based on the absence of oxygen.
Can you give me a for instance when you would see that? Like, what would signs be? Like perfusion? How would you monitor that and figure out, okay, he's having breathing problems or something, we gave him oxygen.
And he's getting worse.
Yeah, like how
You
is
could
he
see
cyanotic?
his SpO2 levels should rise to start with, but his respiratory rate would lower. His SpO2 levels, when he stopped breathing, obviously would go down, right? That's the same way for any person with respiratory distress. It's going to be symptomology more than signs. So if your patient has COPD and you've provided them oxygen and they start complaining of having difficulty breathing or increased difficulty breathing, then it might be because of the oxygen. But the only real way to tell would be to remove them from oxygen and see if they start breathing again.
Because I'm guessing COPD, they're going to struggle to breathe always.
They should be struggling, well, should be.
It's gonna,
They often are struggling to breathe.
I think it would be like insane because if they're struggling to breathe, you would think, oh, give them oxygen.
I'm going to give them
But
oxygen,
then,
yeah.
You know what I mean? Like you'd be essentially killing them and thinking you're doing the right thing.
Right.
So it's just a difficult situation, I guess.
It is a difficult situation. So we don't withhold oxygen from someone who we think might need it.
Give it to them and hope for the best. Huh?
All right. Okay, so we're going to talk about ventilation now and the process of ventilation. What is ventilation again?
Air moving in and out of the body.
Yep, it's the mechanical process of air moving in and out of the lungs. Okay, so air moving in and out of the lungs is ventilation. we're going to define a couple of things, and then that'll help us to determine if a patient is breathing adequately. What is tidal volume?
The amount of air that's moved in or out of the lungs in a single breath.
Okay, so if you are sitting there just the way you are, and you're breathing in or out, the amount of air that you move is your tidal volume. Okay? Can you change your tidal volume?
Mm-hmm.
How are you going to do that?
Take a deep breath.
Take a deep breath. Exhale really hard.
Yawn.
You could yawn. Okay. What is your inspiratory reserve volume?
The deepest breath you can take.
What is it?
The deepest breath you can take after a regular one.
Right. Inspiratory reserve volume. Okay. Everybody take a breath. Did you breathe in? Okay. Mariah, did you breathe in?
Yeah.
Okay. I want you to, everybody breathe in. Now breathe in even further. You can't let it out. You gotta follow directions. Okay, everybody breathe in. Breathe in again. That space right there from your first inhale to when you end your second inhale, that's your inspiratory reserve volume. Okay? What's your expiratory reserve volume?
Blow all your air out, and push more out.
Blow all your air out, push more out. So that's what we're going to do. Blow it all out. Did you do it? You snorted, but did you do it? Expiratory reserve volume. Blow it all out. And then again. Yes. Didn't look like you did it.
Well, I did.
Got to participate in class here. Okay. As much air as you can force out from your first exhale to where you got finished, that's your expiratory reserve volume. Okay? There's still air left in there. Your alveoli are still open. That air that's left in there is called your residual volume. Okay. Do you remember our drawing of our person, our anatomical drawing of our person? And we had air tubes that didn't have any alveoli, right? We have our nasopharynx, our oropharynx, our pharynx, our larynx, our trachea, our right and left mainstem bronchi, and our bronchioles. There's no gas exchange happening in those spots because gas exchange only happens in the alveoli at the alveolar wall. So all of those places where air exists but there's no gas exchange happening, that's called dead space. All of this is important. And then we have minute volume. What is minute volume?
How many breaths you take in a minute? Or
It's based on how many breaths you take a minute. But minute volume is your tidal volume times your respiratory rate. So, how do you figure out what your tidal volume is?
Spectrometry test.
How are you going to know if you've got enough air moving for it to be adequate respirations?
is that the 500 milliliter thing?
Okay, so let's use 500 milliliters as a good amount of air exchange, okay? So if we have 500 milliliters, that's per breath, and we are breathing 20 times a minute, what is our minute volume?
10,000.
10,000. So in a minute, we are exchanging 10,000 milliliters of air. That's pretty good. for you to be able to tell if your patient is breathing normally or adequately, do you need to know what their tidal volume is? Do you need to know you are breathing 498 milliliters per breath?
No.
No. Why not?
Because don't you just need the inspiratory and the expiratory volume? However you get that.
Inspiratory and expiratory volume are kind of our leftovers. That's really the last thing that we consider or worry about.
Oh, okay.
But we don't really worry about tidal volume as a number because we can see if a person is breathing normally. What does a normal breath look like? It doesn't,
Yeah, it doesn't.
right?
Yeah.
It doesn't. What does a shallow breath look like? Anyone?
Yeah. Hyperventilating.
So those were shallow respirations, but what happened to my respiratory rate? My respiratory rate increased. So I've got shallow respirations, but my respiratory rate increased. What do you think happened to my minute volume? Pardon?
Increase.
Okay, so our original tidal volume, our original minute volume, so minute volume is tidal volume times respiratory rate equals minute volume. In our original equation, we had 500 milliliters times 20 respirations equals 10,000 milliliters, minute volume, okay? So let's say that my shallow respirations are moving 250 milliliters of air.
But with 40.
But I'm breathing at a rate of 40 per minute.
You're getting the same amount.
I'm getting the same amount of tidal volume. Right? Am I breathing adequately? Why not?
Because you're breathing too fast.
I'm breathing too fast, but why does that mean I'm not breathing adequately?
There's the time for the, I keep wanting to say diffusion
Diffusion?
to occur is probably not there.
That's part of it. If I am breathing at a rate of 40 respirations per minute, I'm not getting any gas exchange in my alveoli. All of that air is coming from my dead space.
That's right.
Okay? Since all of that air is coming from my dead space, the air in my alveoli is not getting replaced. So I'm moving air in and out, and I'm moving it in and out really fast, but I'm not moving it in and out correctly. Now, what if my respiratory rate is 750? I'm sorry, what if I'm moving 1,000 milliliters per breath and I'm breathing at a rate of 10 per minute?
You're still getting the same. It's just, you're probably getting more oxygen.
Am I moving the same amount of air? Yeah. Which one do you think is better for me? If I had to choose between this one and this one, which one's better for me?
Probably the bottom one.
The bottom one. Because this is going to make sure that I'm getting at least some type of gas exchange down at the alveoli, and this one isn't. Okay? So when you look at your patient, because really 10 breaths a minute is too low. What's our normal respiratory rate for adults?
12 to 20.
12 to 20. So 10 breaths a minute is a little bit too low, but it's okay because even though he's a little bit too low, he's breathing fairly deeply. And those fairly deep breaths, they're going to make sure that his minute volume is okay. Now, you don't have to know he's moving 1,000 milliliters per minute. Can you watch him and see if he's breathing deeply? Yeah. If he's breathing deeply, but he's breathing slowly, he might be asleep. Right? But he probably has appropriate gas exchange. Okay? What are some characteristics of normal breathing?
Normal rate and depth.
Normal rate and depth. What's the rate again?
12 to 20.
12 to 20. And you can tell when a person is breathing deeply or shallowly just by watching them. So, normal rate and depth. What else?
Regular rhythm or pattern of inhalation and
Okay,
exhalation.
so we have a regular rhythm.
clear, audible breath sounds on both sides of the chest.
Okay, so if you listen with your stethoscope, you should be able to auscultate clear lung sounds. Okay, what else?
Regular rise and fall movement of both sides of the chest.
Okay, so we have regular chest rise and fall. If you are ventilating a patient with a BVM, we call this equal and bilateral chest wall movement. So if we use a BVM on that guy right there, we watch his lungs inflate and they both inflate together, that's equal and bilateral chest wall movement. Okay? And then we also have movement of the abdomen. This movement of the abdomen is more pronounced in babies. Because babies are belly breathers. Their bodies are shaped a little bit differently. Their ribs are shaped differently. They're more horizontal instead of like curvy. They're more horizontal. Their diaphragm sits below their ribs. So when they breathe in, you can pretty much see their diaphragm moving, but it's their belly, right? Okay. What are some of the signs of inadequate breathing?
Cyanosis.
Cyanosis?
Muscle retractions
Muscle retractions. Where are we going to see muscle retractions at?
above the clavicles, between the ribs, below the rib cage.
Okay, so our muscle retractions are going to happen right here, okay? It'll look like that. You have muscle retractions in those intercostal muscles that we were talking about a little bit earlier, and then below the rib cage you'll see some muscle retractions. Okay, what else might we see?
Pale skin.
Pardon?
Pale skin.
They could be pale, yeah. What else?
Cool or damp skin.
Okay. What else?
Tripod position.
What's the tripod position?
Like your hands on your knees, bent over.
Yeah, you're breathing really hard. You can tell you're breathing really hard because you're working so hard that you're breathing really hard, right? We have a tripod position. Okay. How do we help a patient who is suffering from irregular or inadequate breathing?
Give them oxygen.
Give them oxygen. How are we going to give them oxygen?
With a mask.
With a mask. Do we have a couple of different ways to give them oxygen?
Nasal cane or bag valve mask.
Okay, so we have a nasal cannula. We have a non-rebreather mask. And we have a bag valve mask. Okay, so we use three oxygen delivery devices: nasal cannula, non-rebreather mask, bag valve mask. This is not a very popular method of pre-hospital oxygen delivery. If a person needs oxygen in the pre-hospital setting, they probably need oxygen via non-rebreather mask. However, it is still an option that is available. Not a popular option, but it is an option that's available. And we use it when we need to do blow-by oxygen on babies, or if we have an older child or an adult patient who doesn't want to wear a mask. They refuse to wear a mask. Okay? For a nasal cannula, you deliver 2 to 6 liters per minute of oxygen. For a non-rebreather mask, you deliver 10 to 15 liters per minute. And for a BVM, you deliver 15 to 25 liters per minute. And when we get into airway management, which I think is chapter 10, we will spend a little bit more time talking about those oxygen delivery devices and how to use them. Okay. The last thing that we need to talk about in the respiratory system is agonal respirations. What are agonal respirations?
It's an abnormal breathing pattern by slow gasping breaths, and sometimes you can see it in cardiac arrest.
Okay, it's an abnormal breathing pattern which kind of looks like the patient is gasping, and you can sometimes see it in cardiac arrest. You can sometimes see it in someone who has just recently died. They appear to be breathing, but they're not actually breathing.
Seen I think she was 9 years old, the girl that did one. She's pretty well dead, but yeah, she was still like gasping for air. And every deer I think I've ever shot does it for a while.
All right. Any questions about the respiratory system?
No, I actually got this one.
All right. Let's go ahead and turn that off.